Welcome to Dental XP. I'm Dr. Álvaro Ordóñez from South Miami, Florida. Thank you for being here today with us. This webinar is an introduction to the clinical applications of zirconia implants, and it describes techniques and methods to computer guide them and restore them utilizing technology that is now available in almost every country. Feel free to email your questions to Dental XP. I will be happy to assist you with the answers. This presentation has been made possible thanks to the companies and a group of friends in the dental industry that provided training, biomaterials, advice, and even friendship. Thanks to all of you. The whole idea of this presentation is to describe an alternative technique to computer guide zirconia implants and restore them aesthetically and functionally. We will have a brief introduction about the nature of the zirconia implants. We will review the aspects related to alternative advanced cone-beam CT image that could be utilized in a case like this. We will also review the steps to organize a computer-guided case, and we will then present a case that involves natural teeth and implants, extractions, socket grafts, denting, and sinus elevation. In this case, 6 zirconia implants were computer-guided and restored from the beginning to the end. At the end of this presentation, you should have a solid idea about the clinical protocols for planning and computer guiding a zirconia implant, utilizing the Universal Guide by Materialized Dental, as well as information of different aspects related to the zirconia implant surgical and restorative protocol. C-Systems is a leader in zirconia implants with thousands of implants successfully placed and restored. It is a Swiss company, and we all know about the quality controls of their fine and precise technology. The dentist that developed this system was Dr. Ulrich Vance, who was facing the necessity to have an alternative to titanium for his patients. He then approached Metoxit, a company dedicated to the biomedical and industrial production of zirconia. The rest is history. This system has been evolving, and there is a dedicated team working to make it better and more predictable every day. One of their major improvements to the zirconia implant was a major surface treatment modification, which is now laser modified. They just recently launched their 2-piece zirconia implants, which is awaiting FDA approval in the USA and should be soon in the American market. When we think of zirconia implants, we should think of zirconium dioxide, a material with more than 30 years of applications in dentistry and widely used in orthopedics. This material is mixed with other components to increase flexible strength and add long-term stability. There is a sintering process and an additional process known as HIP, or hot isostatic pressing, which dents the crystal structure and keep the flexible strength of the biomaterial. As we mentioned before, the zirconia implant involves a very complex laser modification process that is not applied to the bottom of the threads to avoid reduction in break strength. This laser treatment provides an enhanced surface that facilitates the osseointegration process of the implant. The result of this surface improvement is an increased surface roughness when we compare the new laser surface treatment to the roughness created by the previous sandblasting technique. And as I mentioned before, it's a company that has been undergoing evolution. The manufacturing process consists of 8 steps that go from the manipulation of the powder to the final cleaning of the implant. The powder is mixed with aluminum dioxide and yttrium oxide to improve flexible strength and resistance to aging. The material is then subject to a process known as HIP, or hot isostatic pressure. This process makes the crystal structure more dense and more flexible. The zirconia is then taken to a 5-axis diamond milling machine, a process that creates an implant in 45 minutes of precision milling. The implant is then surface treated, utilizing the laser technology to create the raw surface of the implant, and after this, the implant is cleaned and sterilized. This material is highly resistant to any kind of forces. It has been subject to all kinds of laboratory testing, and it has been utilized in implant dentistry clinically for 12 years. Biomedically, it has been used for more than 30 years, and it is a material with excellent density, hardness, flexible strength, and modulus of elasticity. There are several advantages and benefits when using zirconia implants. My personal favorite are the lack of tattoo effects and great shades, the beautiful response of the soft tissues, the aesthetic reliability, and the fact that we now have an alternative to titanium. An alternative that now has the highest certifications in quality control that include the ISO certifications, the European Community, and the FDA certification. These are the original implants and restorations utilized for testing back in 2001 by Dr. Vols. The results, as you see, were impressive. There are several studies conducted by important clinicians and research groups and educational institutions all over the world. Many more studies are being conducted as we speak. Speaking now about some aspects related to the implant placement strategies, it is important for the clinician to position the finish line about 2 mm subgingival. The implant collar is the point of reference utilized to position the implant in relationship to the gingival margins and crestal bone. It gives us some range that we can play with to place the implant lower or higher depending on our clinical necessity. The company protocol recommends placing the implant as parallel as possible, no more than 20 degrees of inclination, if any inclination at all, therefore being an implant system that would greatly benefit biomechanically from computer-guided protocols. There are some basic rules to follow when dealing with zirconia implants. Just to mention a few, in large defects, it's better to perform the surgical repair, allow sufficient time for the area to heal and bone to regenerate, and then come back and place the implant. So this is not an early placement implant. It is an implant that requires a good length of bone and good width. The minimum vertical quantity of bone is 7 mm according to the protocols, but personally I feel more comfortable with longer implants, especially with this system. It is just a personal choice based on the population of my practice, which are patients with parafunctional habits and TMJ disorders. The management of the site posterior to implant placement becomes important for success. Most clinicians recommend that the implant should be kept away from forces. Therefore, it is important to create a prosthetic environment in which the implant is completely isolated from masticatory and lateral forces. There should be a protective space of 1 to 1.5 mm from the abutment whenever fixed or removable temporary prostheses are being utilized. As we mentioned before, this implant system requires the best possible parallelism with divergence that should not exceed 20 degrees. Therefore, the computer-guided protocols become a great supplement for excellence in placement. This technology has been evolving and continued to evolve since the beginning of Combin City in the early 60s. Dr. Albert Mattia and Michael Picos refer to it as the most significant development since the work of Brandenburg. And it is indeed, as implant dentistry protocols are being rewritten based on all the new advancements related to the fields of imaging, laser scanning, 3D milling, and printing that are making 3D implant dentistry a reality. The main advances related to computer-guided protocols are related to the ability to prepare most components and parts before the actual work is being done. Every day more dentists are sharing digital files with their lab, and stone and impressions are progressively being replaced. In some practices, by scanning and printing or milling. This technology requires a financial investment and an investment in education, but also in becoming familiar with the machines and software before it is even implemented in a practice. So at this moment, it's better to work with a third-party company that can provide clear protocols and guidance to the dentist. Intraoral and countertop scanning is now being performed in more dental practices. More dentists have now digital labs in their practices. These digital labs have Combin CT scanners, laser scanners, 3D printing, and 3D milling machines that can provide a full scope of solutions. Abutment, frames and crowns, can be generated from an intraoral optical impression, and the dental labs can become certified in this process to work with this technology. The communication becomes virtual, and it can all be done utilizing the internet. Models can be printed easily and at a low cost in an office or by any lab with a 3D printer. There are milling and printing machines specially designed for dental practices and dental labs. But everything begins with the initial comprehensive exam, a good diagnosis and treatment plan, and generating good diagnostic images. The interactive software becomes then the connection to put all this together so the case can be analyzed and planned. The surgical guide is performed, the implant placed and then restored, all this with precision and safety. Computer-guided protocols are becoming more sophisticated, and the two main protocols recommended today are the dual scan and the optical scan. The dual scan is utilized mainly in fully edentulous patients, with some exceptions. This consists in placing some markers in the denture, then scanning the denture, the patient, and bringing the data to the software to analyze and plan the work. The optical scan is the other advanced protocol utilized for planning a computer-guided case. The data is captured intraorally or from models using an intraoral scan or a tabletop model, and it is then imported into the interactive software. Any artifacts are removed using the optical data as a guide. This is a technique-sensitive procedure and very delicate and time-consuming. Errors in this process come back at you at a very hard price, therefore the need to learn or work with a knowledgeable mentor in this area. We have been playing with optical scans for the last 4 or 5 years, and we have been able to develop some protocols to implement this technology in our everyday implant dentistry. As you see over here, we have two different sets of models. The pink model is the optical scan of a patient without temporary crowns. You can see the crown preps and you can see the edentulous spaces. The white model is an optical scan of the same patient wearing his temporary crowns. What we have done over here is that we have made a third optical scan of the mandible, the mandibular arch, and now we have one of the models articulated with the other model with a separation of about 5 mm between the mandible and the maxilla. On the right side of the screen, you're going to notice that we have overimposed the white model with the pink model, the white model being the model with the crown prep and the edentulous spaces, and the other model being the model with the temporary crowns. What you see now is the zirconia implants being planned utilizing the existing temporary crowns at the point of reference. So doing that, we can actually plan the lateral and the anterior, posterior and superior inferior position of these implants. We also have overimposed the bone, the soft tissues, and we have a perfect reconstruction of this patient. Doing this, we're able to actually select the best position in any kind of area for this patient. Once you are happy with the position that you have selected for the implant, with the diameter, with the width, with the brand, with the shape, with the silhouette, all you have to do is proceed to build your surgical guide. And all this information is emailed to the company that you are working with, in this case Simplant Materialize, to have the surgical guide fabricated. You can here appreciate a video that shows the final positioning of the implant, the reference of the nerve in relationship to the upcoming position of the implant, as you see, these zirconia implants are a monoblock implant. There are now 2-piece implants being fabricated. What you see here is an overimposure of the implants with the optical scan of the abutments and the edentulous spaces, and you can see all the soft tissue volume, which is an important information that you can now introduce into your treatment planning process. You know exactly where the nerve is located. You can overimpose the second optical model, the one of the temporary crowns. And thanks to this type of technology, you can do the best possible planning and facilitate the surgical process once you're ready to start conducting the surgery in your patient. So my advice to you and my recommendation to you is try to implement this kind of technology and take advantage of the alternative that you now find in implant dentistry. Zirconia implants are great. Zirconia implants work. They are going to give you the most beautiful restoration that you have ever worked with, but they are delicate, they are technique sensitive, and the most care that you take and the most precision that you work with, the better results that you're going to obtain. The biggest complication that you can have related to optical scanning have to do with the correlation process. If you don't have a good point of reference and you don't correlate the two structures, being the bone volume of the cone beam CT with the actual scan that you have performed, what's going to happen is that you're going to have a model that is off, like you can see here in this image. See how the whole silhouette and the whole structure of the optical scan is being off, and it doesn't match the actual volume of the cone beam CT. The other thing that you can see is that the sizes don't match either, so there are multiple mistakes in this type of procedure. So another situation that you have is that when you are performing this type of models, if you are using a countertop, you need to trim all these edges, because otherwise the appearance is not going to be the best, and it's going to block some of the other structure that you might need. So remove any stone that you need, trim it before you even scan that model. Clean anything that you need to clean in the stone, and then do the scanning. Today most dentists are implementing intraoral scanners, and it's facilitating this type of work. Once you have decided the type of implant that you want, and in this case we're working with the Z system, and they actually have two different type of implants, or used to have it at the time, which are the Z Look 3 evolution implants and the Z Look 3 implants. Then you go ahead and you make your selection, and you need to decide in the implant library of the interactive software, in this case Simplant, the diameter and the length of the implant that you're going to use. So once you make your selection, you press OK, and now you add that implant into the planning process. You can also do different kind of segmentations, and as you can see over here, these are the two tenting screws that we did utilize to build that ridge. So what you see here is an actual reconstruction of the tenting screws, because we wanted to see what was going to be the interrelationship between the area of the tenting screws with the area of the upcoming implant. So all these are little details that will help you during the case performance. Materialized Dentals has different kind of guides. There is a guide system that is called the Safe Guide, and these guide systems are specific to an implant system. There are different implant systems and different companies with Safe Guide systems. For example, Zimmer, 3i, Biomet, Astra, Dentsply. They have worked in conjunction with Materialized Dental to create a system that is specific to their implants. They call those systems Safe Guides. There is an additional system that is called the Universal Guide, and it's a system that was fabricated by Materialized with the whole purpose that it could be utilized with any kind of implant system. The Universal Guide would be the right guide to be utilized with the C system or with any other implant system that doesn't have a Safe Guide. The Universal Guide is specific to any kind of implant system at all. So if you have an implant system, you can do the surgical procedure utilizing the Universal Guide. The patient case that we're going to be seeing now is a 53-year-old male. He'd been diagnosed with heavy metals poisoning by a physician in Europe. He's an alternative medicine doctor and don't want any metals. So he was going to travel to Europe to get non-metal implants, and he was going to get some zirconia implants. He was introduced to me by a friend several years ago, and part of my disclosure during my informed consent was to explain to the patient that zirconia is considered a hard metal, and if you go to the periodic chart of elements, you're going to find it listed as a metal. It is resistant to corrosion and is similar to steel. So it's important that he understands that from the periodic chart of element standpoint, he's getting a metallic implant, so he's not technically being completely freed of metals. Our process or our protocol consists of doing an exam and a diagnosis. Then we do our cone beam CT, and as I said, there are different protocols for doing the cone beam CT imaging. For this specific patient, we decided to put these apart, but one of the new modifications that we're doing to our protocols is that when we're optical scanning, we're not separating the teeth anymore, because it's going to give us a bite, and that bite is very important during the planning process. We used to separate the teeth because it was easier to separate the mandible and the maxilla, but we would not have that issue if we are working now with optical scanning. Then we proceed to do the intraoral scanning with and without temporary crowns, and then we proceed to scan the models with a tabletop scanner if we need that. There are some cases in which we do up to 4, 5, 6 different type of scanning, and it becomes easier to scan models instead of doing intraoral scanning. Intraoral scanning takes longer. Then what you need to do is import the data to the interactive software and start planning the whole process. From there, you place your implants, you design and order your guide, and you're ready to do your surgery. This is the patient with the existing porcelain fused to metal bridge, a failing bridge that had already become separated. You can see that the centrals are indicated for extraction, big lesions, big mobility, failing root canals. This molar is also indicated for extraction. There is an edentulous space in this premolar area and in this premolar area, and we're going to have to elevate the sinus here. Implants are going to be placed, and it's going to be 6 implants for this specific patient. You can see the maxilla, and you can see the defects, the bone defects, which we're going to try to improve. Hopefully we're going to try to completely correct. Those are the teeth that are going to be atraumatically extracted. You can appreciate the defects even better. But the first thing that we need to do is remove the actual bridge and prepare a temporary bridge. We decided to use the eggshell technique, prepare a set of temporary crowns, and get ready for the atraumatic extraction and the socket preservation. Additionally, we're going to have to also tent the adjacent area, the area of number 7, to enhance that bridge. This is the process of extraction and socket graft utilizing the PDL luxator, which is a nice luxator kit that is distributed by Southbeam Dental. The particulate graft material is Ora graft, cortical and cancellous, which is also distributed by Southbeam Dental. We use the PRF membranes, and we utilize the Southbeam Dental centrifuge. Excellent result. We have been using that for 4 years, and it works excellent, better than any other PRF machine out in the market. The clinical results are very similar. So from the socket preservation area, and here you can appreciate the position of the actual biological membranes created with the PRF. From there we move to the number 7 area, and we open a full thickness flap, and you can appreciate the severity of the defect. We placed 2 tenting screws, and this is the Profit kit by Osteogenics. Osteogenics is a leader in bone regeneration and biomaterial products. They fabricate excellent membranes. and excellent fixation screws and bone substitutes. We proceed to put particulate bone and a TXT 200 membrane, which is a membrane that we use most of the time for socket preservation, but it's a membrane that you can actually submerge and utilize it for heavier, bigger defects. This is the final site after suturing and primary closure, and you can see an immediate improvement of the defect. There is some mucosa in the area. Hopefully when we get back in there to place the implant, we will be able to correct that defect, that soft tissue defect. Then we go to the molar and we divide the molar, separating each one of the roots, and we independently luxate and extract each one of those roots, utilizing again the PDL luxator kit. Then we go ahead and we use the Sommer osteotomes and we try to push up that base of bone and that floor of the sinus, grab the area with some autograft and try to gain some vertical height. So when we go back over there, we have enough length to place the implant. The bone substitute here was autograft, cortical and cancellous. We also used Salvin PRF and a TXT 200 membrane. The patient comes back 4 months later for the computer-guided surgery. This is what we see now, and we can see the improvement in that reach. We proceed to do the try-in of the surgical guide. We like to use the Dr. Thompson sticks to mark the areas where we're going to be doing the surgery. And we did some of the implants utilizing a tissue punch, minimally invasive surgery. And these two implants, 7 and 8, we had to open a flap. Observe the perfect parallelism, super nice parallelism, long implants, and the patient is now ready. We need to proceed to remove the top of the implant, which is the one that is utilized for the insertion tool. What we're going to see next is going to be a video of the computer-guided surgery. This is the surgical video of the computer-guided placement of the 6 zirconia implants, and at this point we're trying the surgical guide and we are checking for the proper fit. It fits really nice. It sits on the existing teeth of this patient, and we're utilizing Thompson sticks to mark the intended areas where we plan to put the implants. Now we remove the guide and we see exactly where we want those implants placed. So some of those implants are going to be done with a minimally invasive technique utilizing tissue punch, and these are Salvin tissue punches. Look at the beautiful quality of the adjacent soft tissues. We're able to get a nice regeneration of the area. Look over here. Beautiful tissues, beautiful. I'm very happy with the result. In this area, remember the big defect that we had in the beginning. Look at the nice repair, and also remember we had some mucosa over here. We put the PRF, and now we had a beautiful improvement of the site. We're doing an incision, and we're going through the margin of the canine, and we did an oblique incision in the midline. This number 10 is also being punched, and we are opening a full thickness flap, and we see the TXT 200 membrane, which we are going to remove now. There is a small defect in this area, which will graft with particulate bone with autograft. The tentin screws are being removed. They did their duty, which was to maintain the space. And we are utilizing the Profit screwdriver to remove that screw. This is the universal guide. It is a series of sleeves that fit into the rings of the surgical guide, and these are the zirconia burrs of the kit. And we are just going through the process and protocol for the implant placement. The universal guide has different sleeves in every single possible size that you can imagine, in every diameter, so it fits any burr of any implant kit. So we're just going around the arch, then we go to the next burr and we do the same until we get each one of the implant sites prepared. So it's a very simple and easy procedure, because all you have to do is follow, get your burr into the sleeve, and all you have to do is follow until you feel that there is a stop. It is a clean and it is a fast way to work. It's a nice system. We're now working with the 3.8 burr, and notice that the handle, which helps to keep the sleeve in place for the surgical guide. So it is good because it facilitates access and control on the actual guide sleeve. Now we have each one of the sites prepared, and we're going to proceed to place the first implant. The implants come with an extension for the placement tool, which you can see over here. That extension is removed later with a diamond burr, and the implant is slowly being driven into the site. Notice the actual flat in the abutment, the anti-rotational component for the prosthetic component. Now remember that collar that we mentioned. We have positioned the base of the collar at the level of the crest. That collar is now a transitional area for the soft tissues. This patient has a very nice biotype, so we have a good volume of soft tissue. Second implant has been placed. We're going to place now the third implant. It is a nice and simple implant system. You have to follow each and every indication of the company, of the manufacturer. Zirconia is strong, super strong. It's very hard to cut. It's very resistant to forces. It's very resistant to impact. I used to think that zirconia wasn't as strong as it is until I started playing with zirconia in crown and bridges. I thought that the implants would be easier to prep and cut, and it's super difficult. It's easier to cut metal than to cut this zirconia. These are burrs that are provided also by the company. And we're removing the extensions for the placement head. Now the 5 extensions have been placed. We're going to delay the placement of the 6th implant, which is the implant that is going to go in the sinus elevation area, which we haven't done. We're polishing the coronal surfaces, also with a diamond burr that have been provided by the company, super fine burr. These are the gingiva formers which are placed in the area, and we're not going to put a temporary crown in that one. It's just going to stay in place with the gingiva former. We're going to modify this gingiva former to be inside the temporary crown. We are adding additional particulate bone, cortical and cancellous material, putting PRF again, solving PRF, and we're gonna primary close. This suture is nylon 6/0, super clean, and it's also a very affordable type of suture. But what I really like is the fact that nylon is extremely clean. It can sometimes pinch the soft tissues of the patient. If patients complain or if you see anything, you can take like a hot instrument and make the tip dull with the heat, the tip of the area where you did the cut of the suture, and it will be dull and it will not bother the patient anymore. Temporary crowns are now in place and the computer guided surgery is done. Now we're going to wait. So the patient is now going home with the temporary crowns, and during this process the company recommends that we leave a space around the abutment of about 1 to 1.5 millimeter with the fixed and with the removable prosthesis. If we are using removable prosthesis, we need to make sure that there is some space so the removable prosthesis is not sitting on the abutment of the implant. The same with the temporary crown. So this might be about the most difficult part of the whole process and the whole protocol, because sometimes we need or we have some specific clinical situations that might complicate this management. But other than that, this whole system is super straightforward. This is the patient 6 months later, and look at the beautiful soft tissues. Beautiful. I really see it and I don't believe it, especially considering how we started the case. Each and every one of the implants has beautiful soft tissues surrounding it. Super nice. Look at the improvement, especially in this side. Look all this area, how it got better. Also, we remember that we did some grafting over here, and look at these areas. Let's compare before and after. This is how we started, and this is where we are right now. So it's a major improvement of the architecture of that maxilla. Not perfect, but super good. What we're going to do next is that we're going to do a standard crown and bridge impression. We're going to get our cord, our hemostat, it's 00 cord, the thinnest cord that we have, and we're going to pack it double, and we're going to take an impression. That impression is going to go to the lab. If you're using intraoral scanners, for example, you could do a full arch intraoral scan. We're also going to go ahead and we're going to utilize our face bow, because we're going to do a major reconstruction of the occlusal plane, and we also want to reconstruct our curve of SP. So we're taking our relationship of the two condyles and the maxilla to transfer that to the articulator. This is the sinus lift right after the sinus elevation, and this is a few months later. we can see that the bone is now being integrated. Now the patient is back and we're gonna do the additional implant. So we go ahead and we put the guide and we can see actually the precision of the actual implant placement. This is the implant, and we're gonna tissue punch the area, minimally invasive surgery. Look at the soft tissues again. Remember that we did some work over there before for the sinus elevation. We start with the pilot drill and we continue with each one of the drills, and I'm showing this way so you see the actual sequence, but this was also computer guided. The implant being picked up, taken into position, and the patient is coming a few weeks later for the delivery of the IMAX crowns. With that specific implant that we just placed, we had to wait additional time. We did not restore all the implants at the same time. So now the patient is back. One of the things that we know that we're going to have to do is we're going to have to do a laser gingivectomy to try to get those margins at the same height, level the margins. And this is the work that we get from the lab. I like my my technician to do some characterization and some staining in my ceramics. The technician was Rafael Santrich, who is a certified dental technician in Aventura, Florida, one of the towns in Miami. He's a great technician, great ceramist. And these are the crowns before cementation, just to make sure that they are going down and that they are fitting. So none of these crowns has yet been cemented, but we are making sure that we are seating the crown well. We need some correction over here. Other than that, everything is looking good. These are again the crowns during the delivery process, and this one is going to have to wait a few more months for the delivery, so we're going to put a temporary crown there. This is the first try-in. The technician had to do some modifications in relationship to the interdental contacts, and he had to get some of the interproximal contacts remodeled so food wouldn't be getting packed in between. This is a close-up shot during the cementation process also, right after cementation. And again, the translucency, the colors are beautiful. Look at the gingival stippling over here. And one of the things that most clinicians have the tendency to notice and to mention with this system is that they notice that there's minimal loss or no loss at all of the gingival architecture. In fact, there seems to be a regeneration of the oral soft tissues, especially at the level of the papilla, perhaps because of the actual design of the implant itself plus the biomaterial. A very, very happy patient, very happy. And he's actually in the field of alternative medicine and bioenergetics, so he has many patients that are likely going to need these implants. Hopefully I'm going to get the referrals. And he's going home super happy. Our conclusion is that for any type of procedure in implant dentistry, you need to follow a process of planning and performance. The Zirconia implants will provide excellent cosmetic and functional results. They are very strong. The Zirconia implants can be safely and precisely computer guided, utilizing different implant systems, and in this case they were computer guided utilizing the Simplan Universal Guide. Thank you again for your time and your attention, and I hope that this is going to be a good supplement to the implant work that you're doing in your practices. Thanks so much.